So thanks everybody for coming. I'm going to try to stand here in front of the microphone and not move away because I know we're hoping to get this on video too. It's not uncommon for me to stand up and talk to rooms full of doctors and nurses and stuff like that. And I don't often get the opportunity to talk to patients outside of clinic. And so this is a real treat for me to get to talk to patients and to not just patients, to people, I should say. And so I'm really grateful that you guys are here and have been given this opportunity. So I'm going to talk about a couple of things today. One is just to talk about palliative care in general, palliative care and why palliative care is helpful for people who are living with serious illnesses, and then talk a little bit about palliative care and how it's different from hospice, and then I'll use about half the time to talk about palliative care specific to heart and lung disease, and hopefully leave some space, a fair amount of space to answer questions if people have questions. So you guys may have heard this already or not, but palliative care is really specialized care for taking care of people living with illnesses that we call a serious illness. So illnesses that are serious enough that we worry that the illness might shorten somebody's life, illnesses that can adversely affect someone's quality of life, that can limit how they function, how they carry out their normal activities, that can place a burden on those close to them, people living with them, people caring for them, family members, and diseases for which the symptoms and the treatments can be quite uncomfortable or burdensome. And I like this definition of palliative care because I think it really does focus to sort of why we're here and why is there a specialized field. You know, I actually started my career as a primary care doctor close to 20 years ago now. I had a busy practice in Chicago, and I had a lot of patients for whatever reason, different illnesses for which there weren't good treatments, and I realized I can't cure these patients and these people. I can't make them better. How could I help them? I need to find a way to help them when modern medicine doesn't have a miracle cure. And so I started looking on the internet. You know, this was, again, close to 20 years ago, and I came upon this concept of palliative care as a specialty to help care for patients when modern medicine can't make the illness go away. So that's really what palliative care is about, and that's really why I made a transition in my practice, again, almost 20 years ago. The focus really of palliative care, what we do in palliative care is we really try to relieve both the symptoms that are bothersome and the stress of illness, not just even for the family, but for the patient and everyone around the patient. So the goal is really to improve quality of life for the people living with illness, and again, those around them. Really, anyone who's living with a serious illness is eligible for palliative care. There's no strict criteria or prognoses. You know, we do find that patients who have illnesses that aren't serious, illnesses that are more chronic illnesses that they'll have for 20 years, for 30 years, sometimes our skills aren't as well suited for that. Better really suited for people with those serious illnesses that are really severely impacting their lives. And the other thing just to mention is that we often take care of patients and provide care right alongside we call them sort of their curative doctors or their regular doctors. So, you know, next to the oncologist, patients will be receiving cancer treatment and still see a palliative care provider. Next to their cardiologist, they'll still see us. So we work right alongside. People don't transition to palliative care in that setting. And then this slide I really like too. It really talks about the person behind the disease. And it's really one of the things I love about practicing palliative care is that we get time to get to know our patients. Our job is to really get to know our patients, find out who they are, what makes them tick, what's important to them, because we want to take this whole, who is this person who's living with this illness, and how can we make their life better? And you can't really do that well without getting to know the person. So, and it's the part I really love the most. We're afforded long time in our clinics to talk to patients and in the hospital. And again, we really think about who is this person. I just gave a lecture earlier today about another project I'm working on, and I was trying to think of slides to put up, and I realized I just want pictures of a whole bunch of people's faces, because that's what we do, is we're taking care of people, and that's what this is about. So that's why I really love this focus. And we really work together with your doctors to help in lots of ways, kind of an extra layer of help. This slide outlines what some of those things are. One is really helping to communicate with people and with their families, helping navigate some complicated healthcare decisions, helping with symptoms whenever we can, and supporting everyone else around patients and people, and helping to coordinate care in our complicated medical system. So that's kind of some of the things that palliative care does. And this graphic is what I think is a nice illustration of really what we're trying to do. So we have the person in the center, and a person is really made up of kind of mind, body, spirit, and the community around somebody. And so we're taking care of the person primarily, but we're looking at the physical aspects of what it's like to live with a serious illness, the psychological aspects, the spiritual aspects, and also looking at how the illness is affecting those around them. And to do that, we really need to have a team-based approach. So I'm one person, I can't possibly support all the different aspects of a person's life when they're going through a serious illness. And so we work with teams. We do a really nice job of that at Stanford. We have social workers, chaplains, we have child life specialists. On the inpatient side, we have nurses that work with us. And so we kind of share the work of caring for our patients. And I think we really, by doing that, we're really able to provide much more comprehensive care for our patients. And it also gives us a chance to really support one another as we care for our patients. And this is just to show that the benefit of that extra layer of support. So back 20 years ago when I was sort of internet searching palliative care, there wasn't a lot of data about it. It was just that people thought, oh, this is a good idea. You know, a lot of great researchers have been very busy in that time period and done a lot of studies and looked at patients and people who receive palliative care, and actually find that when they compare those people to people who don't have palliative care with a similar medical situation, the patients who receive palliative care have a better quality of life. Their symptoms in general are controlled better. Their spiritual well-being is improved, their psychological symptoms are better, and when you ask them, they say that they're satisfied with their care. They also spend less time in the hospital, and there's the burden on the caregivers or the people that love them and help take care of them is less. So all sorts of good things really from having that extra layer of support in addition to the care that they were already receiving from the medical team. So is palliative care hospice? So it's now 20 years from when I did that internet search. I still put this slide up here because I still encounter people sometimes that confuse the two, and it is confusing. When I first started practicing, I would see patients in clinic and we would have a great interaction and an hour-long visit, and I get to know them and talk about how we might help. And then I give you my business card to take home that said palliative care on it. And then I get an upset phone call. You know, you didn't tell me that I was on hospice. I can't believe that you're hospice and you lied to me and you didn't tell me this was hospice, because they'd gone home and asked somebody or looked on the internet or something. And, you know, I think now it doesn't do it, but even 5 years ago, if you type palliative care in a Google search engine, you would get a bunch of hospice agencies. And so I think it's really important to talk about palliative care and hospice and how the two are related. So I'm going to do that just for a minute. And when I teach medical students and residents and our fellows and lecture, I like to really show it this way. So there's that big blue circle is palliative care. That smaller kind of gray circle is hospice. So hospice is just one type of palliative care. And hospice is a very specific type of palliative care, and I'll talk about it more in general. So all of hospice is palliative care, but not all of palliative care is hospice. And actually most patients that benefit from palliative care aren't ready for hospice, aren't eligible for hospice. That's how I try to visualize it for folks and think about it in my head. So just because you're receiving palliative care, you're not in hospice. So what is hospice? It's a couple different things. You can describe it in terms of what kind of philosophy of care it provides, what's the philosophy behind it. It's also just an insurance benefit. So pretty much any healthcare you get in this country you get as part of an insurance benefit. And it's a set of services that are a part of that insurance benefit. And the main philosophy of palliative care and why of hospice and why hospice came to be is a way to have to provide care that's really focused on a patient's comfort. When we get to a place in an illness where really those curative treatments really aren't helping and might even be hurting, that we can say, you know, some people get to a point where they say, all this treatment isn't helping me, and I want to focus on my quality of life and comfort. I want to be where I want to be, whether it's at home or with family, most often not in the hospital. So that's the idea, is kind of comfort-focused care so that people in the final months of life can really be where they want to be and be as comfortable as possible. So that's the philosophy behind it. And that's what led to the insurance benefit, which I'll talk about. It started in the 1970s. Medicare started paying for hospice, and then all the other private insurance companies kind of followed. And they made it, and it's now covered by Medicaid and Medicare. And I think now with the Affordable Care Act, all commercial insurances, I think, have to cover it. There used to be some that didn't, but I'm pretty sure that they all do now. To be eligible for hospice, a medical professional, either a nurse practitioner or a doctor, has to say, I'm worried that this patient's prognosis is 6 months or less. I'm worried that this patient has 6 months or less to live. Not 100%, because nobody can predict that it's 6 months, but someone has to make an educated guess. And they really focus more on comfort care. So hospice, because it's for people who are focusing on comfort care, hospice care doesn't cover a lot of we think of more life-prolonging therapies. So things like lots of chemotherapy for cancer, or big surgeries, open heart surgery, long-term intravenous medications, things like that. And I'll talk a little bit more about where this gets a little bit stickier with heart and lung disease than it is with cancer patients. But that's kind of the general idea. Medicare keeps working to kind of try to change the guidelines and make it so that patients don't have to make a choice, that they can just have their comfort care when they want it, and we're making some progress. So when people do enroll in hospice, when they get that point in their lives, this is what's really covered in hospice. So it's a pretty comprehensive benefit. No copays. Once you're on hospice, hospice providers really try to make sure that everything that a patient or a person or their family needs is right there at home with them. So there's a whole team for hospice care, just like with other types of palliative care. The hospice team usually has a doctor, nurses, social workers, chaplains, volunteers who can come out and help with grocery shopping or sit with someone while family goes out, home health aides that come help clean and do chores around the house. Not 24 hours a day, but definitely there to help and take some of the burden off family or loved ones. Most hospice happens at home, and the hospice benefit was really set up so that people can stay at home. There are some situations where people can go elsewhere for hospice and can live in a nursing home and things like that, but most often it's at home. There's always a nurse available 24 hours. So usually on hospice, you get like a button that says the hospice phone number, and you can call 24 hours a day and they'll help you. They won't get out to your house as fast as an ambulance, but someone will talk you through how to handle the situation. Someone can come out if necessary. That would be the on-demand nurse coming to the house. And they really prescribe and provide all the medications related to the hospice diagnosis and the equipment. So hospital bed, chair, walker, or wheelchair, all the medications come to the house, really, so the patient and their family don't have to worry about running around to appointments and getting things filled. It's all there for them. So again, hospital bed. And not providing 24-hour in-home nursing care. There are some situations where hospice will cover a couple days of someone in the house, 24 hours for emergencies. So that's really what hospice provides. Again, very comprehensive care. So now I've sort of talked your ear off probably about hospice and palliative care, and the title of this talk was Palliative Care for Heart and Lung Disease. And as Ashley mentioned, my practice before moving here, my clinical practice was mostly taking care of patients with heart and lung disease in the clinic and in the hospital, and did a lot of work sitting alongside lung specialists and heart specialists and helping them take care of their patients. And what I found and what we know when we look at the needs of patients with heart and lung disease is that they have a lot of symptoms that are bothersome, that their caregivers experience a lot of distress and challenges, and I'll talk more about that in a minute, and that they're often cared for by these complex care team. So it's not just like the primary care doctor and the patient. It's often the heart specialist or the lung specialist and the kidney specialist and this and that. And I'll show you another slide and talk about that. And often, particularly with heart and lung disease, patients and families are often faced with really big decisions to be made all of a sudden that come up. And I'll talk about an example in a minute. And the other thing that I think is interesting is people living with heart and lung disease, often the weakness comes fairly early in the disease, or the inability to do things that they used to do comes fairly early in the disease. So when you have pretty serious heart or lung disease, patients and people are often breathless. They're not strong. They have trouble getting around, taking care of themselves, cooking for themselves, those sorts of things. And there's a whole set of challenges just around that. And that the prognosis is quite uncertain. What to expect for the future is uncertain. So for all those different reasons, palliative care is, I think, particularly important for patients with heart and lung disease. And we'll talk a little bit more. And I will, my caveat, so this slide says heart failure. So I've been taking care of patients with heart failure and patients with other kinds of chronic lung disease for a long time. And what I found is that there's some differences in the challenges they face, but there are a lot more commonalities in the challenges that they face. So rather than have one slide for heart disease and one slide for lung disease, I'm really going to talk about both. This is some nice data from the American Heart Association that they put out on after some research was done on what happens, what's it like to live with heart failure. And the blue is is the first one they looked at is what about your ability to travel? Does your illness affect that? And about 50% of patients, it affected their ability to travel. And then if we look at their caregivers, actually, it impacted the caregivers even more, okay? And then just your relationship with those close to you. Again, more than half the patients, it affected their relationships and their caregivers even more so, again, because their caregivers might be, someone in middle age who has school-age children and an elderly, parent who's living with heart failure, and they're back and forth between those things. The ability to do hobbies, so that loss of function that we talked about can make it really difficult. And then the burden of helping care for somebody who can't do a lot for themselves can often cause those kind of problems for caregivers and make things harder, and even to get to family events. So again, lots of burden just in how people live their lives and the things they do, travel, relationships, hobbies, both for patients and the people close to them. And then this last section talks about depression and anxiety and psychological well-being. And again, it shows that it's really significant for patients with heart disease, and serious heart disease. Over half of those patients have significant depression and anxiety, and that their caregivers suffer from it too. And this is the thing that I actually saw in real time in my practice for years. So when I first sort of hung my shingle and said, I'm going to do palliative care for patients with serious heart and lung disease, I thought I would see a lot of people who couldn't breathe because they had emphysema, or they couldn't breathe because they had heart failure. And what I really got more than anything is people were really struggling with all the losses that the illness brought. And that led to a lot of depression, to a lot of low mood, and also a lot of anxiety symptoms, worrying about the future. The feeling of breathlessness can bring on anxiety. And so the majority of my practice had been really taking care of patients' depression and anxiety, and really helping figure out how can we find meaning in your life and help you manage those things and treat some of those symptoms and support their families and those close to them. So I don't have another slide about symptoms. Again, I really think the psychological symptoms related to the kind of loss of who you are. So there are a lot of patients and people who I've met who being a mother or being a grandmother is one of the most important things to them, and cooking for their family. And they can't do those things. So what does that say about them? Or not being able to work or mow the lawn or go do their volunteer activities. So much of who you are is sort of what you can do. And so patients that are living with a serious illness, when some of that's taken away, there's work that we need to do to kind of help figure out how do you find meaning now in your life when a lot of the things that defined who you are have been taken away from you. And so we do that, with our interdisciplinary team. Another thing I just wanted to mention, and again, I don't have a slide, the other thing that I found a lot of patients with heart and lung disease struggle with is sleeping difficulties and fatigue. And so those are things that we definitely help with, I think more so than for patients who have cancer, for a lot of different reasons. So I'm going to, and I am going to leave room for questions at the end too. These guys asked me to talk all the way through because they're videotaping this, but I'll have room for questions. This is normally I would have asked questions, but I'm not going to, and I'll keep talking. Now I wanted to sort of pivot to that issue of complex care teams. So this is a word cloud. Do you guys know what word clouds are? Sort of ask people, it's a big thing at like conferences and stuff now. Say, everybody think about this and then type something down and like tweet it or text it or something. And then the computer puts it together in this fancy looking word cloud. And I think this one came from probably someone talking to a bunch of patients with heart failure and said, what do you think of, what is living with heart failure like for you? Or what do you encounter? Who's a part of your care team? And they got this big messy word cloud with all sorts of things in there. And actually, it's pretty real from what I see with patients. Actually, saw a patient not that long ago who sees a lung specialist and a heart specialist because the heart and the lungs are pretty closely linked together in your body. And often people have one, they also have the other. This patient also not only saw a heart failure cardiologist, but she also saw a cardiologist who does procedures, and then a regular cardiologist. So 3 cardiologists, a lung specialist. I think she might have had cancer at some point too, so she had a cancer specialist. So people and this is not, I see this all the time, where patients are seeing a lot of different specialists, and so it just gets confusing. What's going on? What are the decisions that have to be made? Who's talking to who? And so a lot of what we do is to try to help kind of clean this up. So this next slide is kind of what the ideal state, what we try to think about is trying to put the patient and those close to them in the center, and then sort of a near circle of providers would be their primary care doctor, their main specialist, so their pulmonologist, their main pulmonologist, their main cardiologist, and then their palliative care doctors. So those 3 doctors and their teams working closely and then sort of reaching out to these other team members when they need to. So that's kind of what we try to do. We try to clean things up a little bit, improve communication, make that kind of messy word cloud a little less messy. And a lot of times it's just us reaching out and calling and talking and trying to figure out what did you mean? You know, I saw your patient and he told me that you said this. Can you help me understand what you were thinking? Often, this probably won't surprise you, but often patients hear different things from a lot of different specialists that are sometimes don't match. And so sometimes our job is trying to figure out what's really the right information. And then I think a really big thing that we do is helping with complicated decisions. So particularly patients with advanced heart and lung disease often face really complicated decisions as their illness gets more serious. And there's actually some data, this is from about over 10 years ago now, but a palliative care doctor actually sat down with a bunch of patients who had heart failure and their families and said, you know, what's going on with your decision making? And they said that they didn't get accurate information about their prognosis, that no one was really able to give that to them, and that no one was really able to talk to them in a way that was thoughtful and careful about decision making in the future. And these patients also had often very, very clear thoughts about what sort of care they would or would not have at the end of their life, and then went on, many of them, to have those things happen to them anyway. So sometimes these patients said, you know, I know that I don't want to be on a ventilator at the end of my life. And then that still happened anyhow. So we know that there's just a lot of work to do around talking about all this, and that they're complicated decisions. And this is just a slide to show some of the things that it's a cartoon from, I think, the Heart Association slide deck. There are a lot of different things that get offered to patients. So modern medicine has exploded since, you know, I think polio vaccine in the 1940s or 50s and the development of penicillin and things like that. There really wasn't that much that doctors could do other than sit, hold your hand, talk to you, kind of what I do now. And then all these wonderful treatments came up, and it's really been amazing. There are organ transplantation for people sometimes whose hearts are failing, and often they can actually do well and live a long time for the right patient, and lung transplants and defibrillators and pacemakers and different intravenous medications, lots of those kind of decisions. Those get brought to patients, procedures. Also, a lot of decisions come up about, where do I live? I'm not safe to care for myself at home anymore. Where do I go? What do I do? I see that a lot between patients and families, people who are living with a serious illness and those close to them trying to support them and then worried that it's not safe. So those kind of decisions as well. So a lot of complicated decisions. And a big part of my training, of all of our training as palliative care doctors, is to learn how to communicate well with people, with their families, really find out what's important, and then really use what we've learned about them and our medical knowledge and knowledge of the situation to help guide people to the right decisions so that they can make decisions that best match their goals and values. And they're difficult conversations. They're not light topics. And so we all have a lot of training. I often think, cardiologists, they learn how to go do cardiac caths, or I'm trying to think, GI doctors do endoscopies, surgeons do open heart surgery, and our procedure, the thing we do that no one else can do quite as well, is talk to people about what's important when the stakes are high. So those are some of the things we talk about. The other thing we talk about is hospice, and sort of when is the right time for hospice. And I'm actually going to jump forward to this slide first and go back to the other one. But hospice, I talked about hospice, in the beginning, was really designed to help people have comfort-focused care at the very end of their lives. And it was designed with cancer patients in mind. So really the hospice benefit came along because a lot of nurses who were taking care of cancer patients in the 1970s said, we need to make this better. And it was really designed around hospice. And so the hospice benefit doesn't fit so nicely with people who don't have cancer. And again, Medicare is working on changing it. Everybody's working on changing it. But that when someone has really advanced cancer, it's not that it's easy, but it's easier to get a sense of if we're in that space of time being as short as 6 months. It's much, much more complicated with serious heart and lung disease. It's almost impossible. So I have talks that I give, which I didn't decide to bore you on, with all sorts of slides of very smart people making calculators and computer programs and all sorts of things to figure out how much time somebody has when they're living with advanced heart and lung disease, and they're all wrong. The most recent paper I found was a paper illustrating how all those other papers were wrong. And so we're left with this just kind of uncertainty that we know often we get to a point where it's not going to get much better, but we don't know how much time somebody has. And so that's when I start to think about hospice, and how do you then decide that hospice is right for a person. And what I found over the years is the biggest thing, and I have this sort of silly cartoon of kind of the talk to the hand, I don't want this anymore about the hospital. So I've often, people get to a point where their lives where they just do not want to spend any more time in the hospital. People living with advanced heart and lung disease spend a lot of time in the hospital often as their disease gets worse because they get short of breath and somebody calls 911, or they go to clinic and they go to the hospital. And often actually being in the hospital, if you have COPD, getting steroids for a couple of days, people can perk up, feel better, go home, do well for, weeks, months. Same thing with heart failure. You can go in and they can give you some medicine and get some fluid off and you feel better. But what happens as those illnesses get worse and progress is that time outside the hospital gets shorter and the time in the hospital gets longer, until people get to a point where they feel like, and I can't tell you how many times a patient has said this to me, I feel like I live here. What's the point? I don't want to live in the hospital anymore. And that's really when we say, well, we can actually do hospice care at home. We can support you and your family and give you as much good time as we can. And as you get more sick and you get breathless, we have ways to provide comfort-focused treatments for you. Okay? So that's really when we think about hospice, really when, for the most part, when someone's ready to stay home. And remember, and I have to talk through patients through this a lot too often, your hospice benefit is not limited to 6 months. You don't just get 6 months that you can use up. I can't tell you how many times a person said, well, I really think hospice would be the right thing for me. I don't want to go back to the hospital, but what if I live longer than 6 months? I don't want to use up my benefit. And it doesn't work like that. It's really that someone has to check in on you periodically and say, I'm worried that this is serious heart disease or this is serious lung disease, and that you qualify, but that I've had patients on hospice for a year or more sometimes because we just really can't predict. And so it goes back to that slide I had at the beginning about the philosophy. When someone has a shift in their thinking about their illness, that they really want to focus on comfort and being at home. And then the other thing that's a little bit complicated too with hospice, so it's pretty straightforward for patients who have cancer often. They get chemotherapy to try to cure the cancer. When the chemotherapy doesn't work anymore, the chemotherapy stops and it's time for hospice. And in heart disease and lung disease, most of the medicines that we give you are medicines to just help the heart and lung disease symptoms feel better. So by treating the heart disease or treating the lung disease, patients actually and people feel better. So it's a very different kind of cutoff with medications. And hospice teams have gotten really good at managing heart failure medicines and lung medicines for patients at home. So again, it's messy. I think whenever I think of palliative care for patients with heart and lung disease, it's messy. There's a lot going on. I think a lot has to do with how much the illness affects that person and the people around them. And so I put that back up there to say that we're here to help you kind of support, patients and those around them in all these different aspects. And just to say that, again, when is palliative care appropriate? So stepping back again from hospice, it's really at any time someone's living with serious heart and lung disease that's having problem with symptoms, needs support for people close to them, even children. We have a really wonderful program at Children's Hospital with social workers that can talk to children, grandchildren, and talk to the people caring for them, figure out how to talk with them, help answering difficult questions or decisions about treatments or procedures, and sometimes just trying to find out, is it time for hospice? I can't tell you how many times a cardiologist has sent me a patient and said, I just don't know if it's time for hospice. And so then we have a conversation and we help figure that out. We have a wonderful palliative care program at Stanford. So we have clinic 5 days a week, both up here in Palo Alto and in the South Bay. All of our providers know how to take care of, even though our clinics are located in the cancer center, we see patients of all diagnoses there. And so everybody knows how to take care of patients who are living with these illnesses. Your doctors can place a referral. You can also just self-refer to our clinic. We sort of made that change a number of years ago so you didn't have to wait or ask. We have telehealth too, so we're working on that. We know that driving in the Bay Area and driving to appointments can be a challenge. Do we have brochures? I think we do. Brochures and cards about the clinic. And here's where our clinics are in the hospital. So we're not on here because we're in Hoover right now, but if you go, the main Stanford hospital is there, then the new hospital, and then the cancer center is off of Welsh Road, and we're in the little building next to the cancer center, and also have that location in the South Bay, which is really easy to find. It's right off the highway. And this is just another slide showing where we are in the South Bay. And I've actually found a lot of patients that prefer to go to the South Bay because it's just easier to get to. So we have a great program in both. And that was sort of the things I was going to say. I'd love to answer questions if anybody has questions. Yes?
When do you need to go to the palliative care?
When, if you're living with heart or lung disease? I really think when the illness is really starting to affect your quality of life. And it could be, you could have symptoms that are bothering you. It could be shortness of breath. It could be trouble sleeping. It could be feeling sad. It could be low energy. It could be that those close to you are having a hard time coping too. Or it could be that there's some decisions, like your cardiologist or your lung doctor, your primary care doctor said, well, we could put you on this new medicine, or we could do this new treatment, and you're not quite sure if that's the right way to go. So I think there's no wrong time to go if the illness is really a burden and if it's serious heart disease. And sometimes we see people and we say, you're doing pretty good. Why don't you come back? And I have some folks that, just come back and see us in 6 months, or call us if you need anything before. And sometimes we see people and we say, you should see us in 2 weeks and we're going to start some new medicines. And so it really depends. Did that answer your question? Yeah. Other questions? Yes.
When I heard that my great aunt was in hospice in the LA area, we rushed down there and not really understanding what was going on. And she had a support team. A day and a night nurse were there, and it took months. And I thought they weren't feeding her, and but they said, oh, she does eat, but I guess when they can't eat, then they stop eating. And the thing was, she called my sister when they said, well, you don't have much time left. So she called my sister. She said, I don't want to die alone, so come and see me right away. So my sister drove down there and stayed with her like 3 or 4 weeks. But I was told that it was horrible for them because she screamed all the time. All day long she screamed because she was in pain from her organs hurt. Her body hurt. And I just think that's terrible. I mean, how can you stand to be around someone, and the nurses too, when someone screams all day long? That would be very stressful for the caregivers. Why do they do that?
Yeah, I mean, that sounds like a horrible situation. I'm so sorry that your family member experienced that. I wasn't there, so I'm not sure what happened in that situation. Most patients, when they're home on hospice, are not in pain. We treat their symptoms well.
Medicine, they gave her painkillers, but it did not do it.
Yeah.
And she was in pain,
Yeah.
and so it sounds very difficult. And maybe something didn't work right. I don't know.
Yeah, I wasn't there, so I can't say, but that's not how it's supposed to go.
That's not normal.
That's not normal, no.
Why wouldn't anyone have escalated that and done something? She had a social worker. She had all kind of support team.
Yeah, and I'm not sure. I mean, normally what would happen is the social worker would come. People can change hospice agencies. People can choose to move from home to a different kind of setting. So again, I can't understand what happened in that situation, but that sounds, and I've been taking care of patients who are on hospice for years, and I have not heard a story like that.
And then her death was terrible. They said, what was she doing? Couldn't breathe. And her favorite niece came in and said, oh no, it's the same thing that happened with my mother. Now I went through now she had to go through the horrible death of her aunt. In that situation. I mean, she couldn't make any decisions. The lady in hospice, she was mostly sleeping and in and out of sleeping at that point more than anything, I was told. We'd been there, and then we came back because I was working, and we didn't stay for weeks. We didn't see it, but that's what we were told. So I don't have a very good impression of hospice.
Yeah, and I'm so sorry again that happened. Again, I'm not quite sure what happened. Most of the patients, we actually do follow up with our patients, and most of our patients have a positive experience in hospice. Most family members, actually the topic of hospice comes up not infrequently when I'm talking to people in clinic, because when I'm talking about hospice, I just ask, have you had an experience? And most people who've had an experience with hospice with the loved ones have a positive experience. It's always really, really incredibly difficult to lose someone, and they feel like, thank goodness we had this opportunity. And sometimes I come across people who have loved ones who have not had good experiences in hospice. So there's no guarantee. I would say the majority of people who I meet who've had a loved one in hospice had a positive experience, and I'm so sorry that your family member did not.
That they do not have drugs that cut the pain, so that you have to live through the end of your life like that before you pass away?
Yeah, no. And again, I'm so sorry. I don't know what happened in that situation. They usually have all the medications that they need.
And numb the pain? It should numb the pain, it shouldn't be like that then, huh?
No,
Something
no.
wrong.
I can't say because I wasn't there, but it sounds like something might have gone wrong.
And no one was there to correct it, and who had authority? Probably.
Yeah, that's a sad story, and I'm so sorry that happened.
And they fired one of the nurses because she gave her the wrong pill, and that was upsetting because they liked that nurse, and then she was gone. I don't know. I
Yeah,
just heard
sounds
things about it.
sounds like a terrible situation.
But they don't
Sure.
starve them in hospice, do they?
So those other good questions. So patients, no one is prevented from eating in hospice. Usually what happens, people at the end of their lives get tired and they get too tired to eat. So food is always available. We would never tell somebody that you can't have food, but often people get to a point where they're just not hungry. And we absolutely would not ever keep food from somebody.
So you can stipulate that you want to die in your home, and they shouldn't take you to a hospital.
Yes. Good questions. Does anybody else have questions? Yes.
Just a general question about the area where you practiced in the cold weather in Pittsburgh and Chicago.
Yeah.
Do you find a difference in the way people live because of that? I mean, when the weather is fairly nice here,
Yeah.
I would think that people have more opportunity to survive a little better.
There's more longevity. So I moved to California, like Ashley said, almost 3 years ago. I have met more people over 100 in my practice in California than I ever did in all the years I practiced east of the Mississippi. And I also don't see many people smoking cigarettes in California. So I don't know if it's that or the weather, or I think a lot of it's being outside. And I actually meet a lot of patients, even patients who are really quite sick, and people who spend a lot of time outside in their garden or going for walks. And what we would do in Chicago or in Pittsburgh is we would send people to the mall to go for walks, with the neon lights. And in here, it's really wonderful.
Just curious, since I'm from Chicago myself.
Sure.
When you were at the University of Chicago Hospital, where did you live yourself?
I lived in Wicker Park in the west side. So I grew up in the near western suburbs, and then I lived in the city and took the drive down, usually down the Dan Ryan Expressway, which was not too scenic. I didn't live down near University of Chicago.
27 below last year.
Yeah, no, I still have family in Chicago still, so I love Chicago.
The south side from Evergreen Park.
Yep. I love Chicago. We often miss it, and we go back to visit. So they're good people in Chicago, but not that much warmth with the weather anyway. Yes.
How do you get the social worker, and are they paid, or are they paid through the hospital?
They're paid through the hospice.
Through the hospice?
The hospice benefit pays for that whole team.
So it costs you nothing, no co-pays or anything like
No
that?
co-pays for that core team that I showed you. But again, sometimes people decide they want more help at home than the hospice can provide, because remember, the hospice benefit doesn't provide around-the-clock care. Sometimes people do private pay health aides or something to be there. So that's something that people do have to pay for.
Who's in charge of that team, though?
There's usually a medical director, there's a doctor who's in charge of the team, and usually nurse managers who run the hospice agencies. But they're all different. There are some little teeny tiny hospice agencies, there are some big hospice agencies, there are some national hospice agency. And that's why I say it's really, I'm not surprised when I hear from different people over the years that they have different experiences, because there's a lot of different hospice agencies.
Well, then how do you go about picking a good hospice agency?
Yeah, it's a good question. So I often have people talk to people close to them in their community. Do you know somebody who was on hospice? Did they have a good experience? Those are some, we will often from our clinic, because we work with so many hospices, there are definitely some that we like better than others. And so we will off the record share that with people. And often different agencies fit for different people depending on where you live and what your needs are. And so particularly our social workers work very closely with the hospice teams. And so what they do is they'll get to know our patients and they'll say, I think this would be a great agency for you. So that's one thing that we can really help with. We can't like say you need to do this one, but we can make recommendations. And people switch hospice agencies sometimes, and that's okay. Yeah.
So with palliative care, is that covered by Medicare or anything?
So it's covered by insurance just like any other doctor visit. So palliative care in our clinics is billed like a doctor visit to your insurance. So usually there's a copay like there would be to see any other kind of specialist. There are other settings for palliative care. Sometimes if people are getting home nursing, they qualify for home nursing. If a nurse coming to look at a wound or to give IV medicines at home, some nursing agencies have a palliative care arm where there are nurses who are sort of trained more in palliative care can come out. But most often it's covered as a part, it's like a specialty payment, just like any other kind of doctor visit.
So like with hospice, a doctor has to say that you only have 6 months to live, but with palliative care, you don't have that restriction at all.
Not at all. Nope.
So you can, anyone can.
Anyone could come. What I do, sometimes patients come to our clinic who really have chronic illnesses, who might have 20 or 30 years to live, and the approach of kind of, and I wish I could sort of speak to more why it is, but our tools are more aligned to helping people who have a really serious illness than people who are kind of living their life for 20 years with their illness. So what I found, we see patients who have a chronic illness and not a chronic serious illness, is that we don't add as much. And those people do better with a really good primary care doctor or something like that, or a pain specialist. But for the most part, we always say, please come. And every once in a while we see somebody who's almost a little too healthy to benefit from us. And then we say, I have some bad news, you're too healthy. We'd still be happy to see you, but that we don't add as much, if that makes sense. Other questions? Is there a great amount of questions for a small group of people? So thank you. Thanks so much for coming out.
Thank you.
Oh, you're welcome.